Dear committee, dear audience, let me present my PhD work. I'm Tímea Lőrincz-Molnár, a pediatrician resident doctor, and my aim is to help children and their families dealing with neurological disorders while improving the diagnosis of paroxysmal events in childhood. During our research, we are differentiating paroxysmal events in childhood using video-EEG monitoring and clinical data. Throughout our project, we are questioning the same clinical question, administering the same PECO question framework, but we conduct two different methodologies. First, a systematic review and a meta-analysis, then a registry analysis. Let me start with my first project. So, the most frequent neurological condition in childhood is epilepsy, approximately affecting 1% of the pediatric population. And one study shows that nearly half of children with paroxysmal non-epileptic events are misdiagnosed. These are events that resemble epileptic seizures but do not involve abnormal electrical activity in the brain. The misdiagnosis is crucial. In case of overdiagnosis, children will face social stigma, and it's also a huge financial burden nationwide. In case of underdiagnosis, there is a still untreated underlying condition, and these children can experience seizure or even status epilepticus with vital instability. And sadly, the diagnostic delay can exceed even beyond 20 years. Now, the current diagnostic method consists of patient history, taking neurological examination, assessment of the home videos where parents capture the potential event, and the EEG examination. But due to the lack of protocols for differential diagnosis, the misdiagnosis is really common. The gold standard is the video-EEG monitoring, which is a long-term continuous monitoring, but it requires special equipment and expertise. It's limited, only available in epilepsy centers. Therefore, our aim is to identify the main characteristics of PNE in children based on video-EEG monitoring in order to help us for a better routine diagnostic method. We have to answer the next question: what are the video-EEG and patient history data differences between epileptic seizure and PNA in children? We are investigating children, we are comparing epilepsy with PNA, and we are dealing with patient data and video-EEG characteristics. And we propose that there are notable semiological differences between the two entities. We performed a systematic search. Our search key focused on pediatric population, video-EEG monitoring, and paroxysmal events, and at the end we ended up with 40 eligible articles. We could further subdivide our articles based on age stratification. We had an infant and toddler subgroup with children aged between 0 and 3 years, a pediatric subgroup with children aged between 3 and 12 years. During the data collection, we could face a high heterogeneity of semiology reporting with more than 340 semiological event types, and based on the Lüders classification, we could subdivide them into the main 28 semiological event types, which can be seen on the screen. All our studies were retrospective cohort studies. Our effective measure was the proportion of children experiencing specific events. Altogether, we could analyze nearly 3,000 children data, which resulted in nearly 90 plots. And let me present our main findings. Our first semiology is the arrest, which is a sudden stop in the activity of children. And based on our results, this semiology occurs twice more frequently among infant and toddler, and this change is statistically significant. The next semiology is the hypermotor semiology, which, as you can see, a hyperkinetic, hypermotor event lasting for several seconds. And it was also more frequent among the child subgroup, 5 times more frequently, and the difference was also statistically significant. The next event is the tonic semiology, which means a sudden stiffness in different body parts of the patients. And as you can see, in all age groups, it was more frequent, and the change in the child and whole pediatric subgroup was also statistically significant. And lastly, the spasm is a sudden muscle contracture, mostly affecting the axial musculature. And sadly, we didn't have enough data to compare, to perform subgroup analysis, but based on our findings, it appeared 9 times more frequently among the whole pediatric group, and the difference was also statistically significant. Our work is unique as it's a comparative study in pediatric neurology with comprehensive methodology and age-specific characterization, but we had to deal with relatively small amount of article. We could perform lower quality statistics, and we had to deal with different semiology reporting methodologies. But based on our findings, arrest, tonic, hypermotor, and spasm events are statistically significant indicators of pediatric epilepsy and could be initially assessed by home videos. And in the other semiology event types, due to lack of statistical significance, children with these events need proper neurological investigation, ideally accompanied with video-EEG monitoring. And we need further semiological characterization, further statistical analysis, and aim would be to perform a uniform semiology reporting system and age-specific differential diagnostic protocol for paroxysmal events in children. And our work is now currently under review at the American Academy of Pediatric journal. And let me continue with our second project. We wanted to further differentiate and investigate the tonic events in the pediatric population using our video-EEG registry. In 2001 was established the long-term video-EEG monitoring unit of the Bethesda Children's Hospital, where children and their families can benefit from continuous video and electrical monitoring. And in the last years, there were more than 1,500 recordings with the aim of diagnosis, differential diagnosis, and pre-surgical assessment of the pediatric population experiencing paroxysmal events. And our aim was to further differentiate the tonic events of epileptic versus non-epileptic origin. As we could see from our data, tonic event was a statistical indicator of pediatric epilepsy. We first started with the registry analysis plan, focusing on the frequency, duration, accompanied semiologies of the tonic event. We received the ethical approval. We could enroll more than 250 patients, and now we are at the data extraction part. So in the last 2 years, as a pediatric resident doctor, I could make part in the multidisciplinary team of the spinal muscular atrophy work group and the Angelman syndrome work group. And I also worked additionally in the pediatric neurology, emergency medicine, and intensive care units. I had the opportunity to participate on several conferences in field of neurology, pediatrics, and epileptology. I was awarded with the best poster presentation and Ola Eva Memorial Award, which awards the best publication in the Hungarian Journal of Pediatrics in 2024. With our colleagues, we had several publications, the most significant focusing on the role of long-term video-EEG monitoring in the diagnosis of childhood epilepsy. And altogether, we are performing 2 distinct studies in order to differentiate the paroxysmal events of epileptic and non-epileptic event in childhood for a better differential diagnosis. Thank you for your attention, and let me finish with the words of Rumi. Every child is a different kind of flower, and all together make this world a beautiful garden.
Maybe then I start with on this.
Okay.
This is a frequent diagnostic dilemma, as you have introduced. So how do you think, because you have eventually seen all of the main symptoms being more frequent in epilepsy patients, but how would you think this could be implemented into everyday practice for pre-screening before, or for maybe kind of stratifying patients that are in more urgent need for a video EEG?
Yes, thank you for this question and this focus, because that's the main goal and idea of our project. So in the pediatric neurology, we are frequently seeing this question, whether it's an epileptic or a non-epileptic event. And first of all, the first question would be the age of the child, because we can see an age dependency in the pediatric epileptic field. So the first focus in our mind would be this question. And in our center, we really focus on the recordings. We ask the parents, the other doctors who are asking the question or seeing the patient to record the video. And this video can be sent really quick to our specialists. And first we stratify by watching these videos, and also the clinical data, the frequency of the events, how it affects the daily lives of the child. And based on these altogether characteristics, we can do a better plan for this children investigation.
And in my everyday experience, so we have a shared ward with the Video-EEG unit. The quality of those videos is very different. So sometimes I think it's difficult to use them as a valid source. Let's say for clinics, are there any thoughts on how to improve this, for example?
We face this difficulty, and we further develop, and we just change the video of our monitor. I think that the video is also important, and the electrical recording is also that can help us to further navigate. And additionally, the recording of the doctor or the EEG assistant or the parent can help.
I was rather referring to those homemade mobile phone videos that are in very different quality, and which makes it maybe difficult to include them on a clinical basis, but also on a scientific basis, because it may introduce bias. So do you have any thoughts on how to harmonize this maybe, or how to come up for these differences?
I mean, maybe we can use AI to better the quality of these recordings, but due to the development of the technology, the video cameras and video tools are even getting better on the phone of the parents.
Or do you maybe also kind of instruct parents on how to take the video, or in which occasion?
Yes, we are. It's a panic situation when the child is experiencing a paroxysmal event, and in most of the cases, in the better cases, these are shorter in time, and most of the cases they don't really have time to react. But yes, we in every case we teach them and instruct them how to act in this situation, but they also have to give the anti-seizure medication, so it's challenging. But if there are more, they are subdividing the task. One is offering the medication, one is recording the video. And in our unit, we most of the cases don't act in the first seconds, because we want to register the electroclinical. So we have a
in the clinical setting we do it like this, but in the home setting, that's what I was saying. It's challenging. Thank you.
Thank you.
Any new questions?
Congrats on your presentation. You had great visual materials of different kinds of seizures, but I didn't see one of a generalized tonic-clonic seizure. Was it just not represented, or did you leave that out from your analysis?
Thank you for this question. So as you can see, we analyzed the tonic-clonic events too. It in this category, it was categorized in the clonus semiology, and we did the analysis on the clonus semiology too, but it didn't give us a tendency or significant change. So it's an additional semiology, which without clinical significance needs further investigation. And it was also really frequent in the epileptic and also the non-epileptic population. So it's remained a challenge for us to differentiate these events based on the clonal semiology.
Thank you very much.
Thank you.
Thank you for your presentation. I saw a very high level of heterogeneity. Could you please tell me what is heterogeneity and why it is present in your results?
So the heterogeneity is a factor with which we can assess the quality and the tendency of our results. And in our case, the heterogeneity was mostly due to the different semiology reporting system, due to the age differences in these population, and due to the differences of the Video-EEG recording techniques, and also the tools used in the studies.
Thank you.
Thank you.
Thank you very much for this fantastic presentation. I just have a question because I am not aware at all about these things, but is there a different response of treatment between the different types of epilepsies?
Yes, yes. Thank you for the question. Yes, the epilepsy is really unique from the point of medical point of view, because we often face with therapy-resistant epilepsies, and we have different etiologies. For example, the genetic or any anatomical differences, or even there are seizures. With other disturbances, and in most of the cases we can see different types of epilepsies which are therapy resistant. Mostly the complex genetic mutations can cause these epilepsies, and they are longer, these seizures, mostly longer and more complex most of the cases.
Thank you. Any questions from the board?
Maybe not, because I'm a pediatric gastroenterologist, but you said these symptoms or these movements can be also in patients who have no epilepsy.
Yes.
And specifically for infants, in which underlying disease can be seen these movements, and how you exclude this disease?
In infants, in the older children, we face more frequently with the psychogenic non-epileptic epilepsies. But in infants, we mostly have paroxysmal movements, because they are experiencing their movements, but we mostly face with events during sleep, the nocturnal events, which can really be challenging to differentiate in point of view of epilepsy.
Other disease, maybe I'm a pediatric gastroenterologist.
The Sandifer syndrome. Yes.
How you exclude reflux disease in these patients and the Sandifer?
In our case, we had to face with the difficulty that the clinician reported as that Sandifer syndrome, and we really had to exclude that, because that was a diagnosis and not a semiology. So in the Sandifer syndrome, I would focus on the semiology, the sudden flexion after eating.
None of them, none of your patients from the population you are investigated have no underlying disease, so no reflux, no treated for reflux.
In our meta-analysis?
No, in your patients.
In video patients?
Yes, in the video patients.
Mostly, it's difficulty.
For example, PPIs or so as not.
Yes, first of all, we are investigating children who don't have other diagnoses, and we mostly can exclude them based on previous diagnoses. We often face Sandifer syndrome, and we start with the general investigations, and we can't exclude them.
Hello. Thank you very much for your interesting presentation. I'm a little bit far away from your field, but I have a couple of questions. First one, you mentioned that frequency of these events also very important. So is it because it's associated with more severe condition regarding this disease? Yes, it's true.
do you want to? Yeah, yes. So I answer separately. So yes, the severity or the frequency of these episodes really affects the child's general lives and quality of life. There are therapy-resistant epilepsies where we have more than 100 seizures or paroxysmal events daily. And there are benign conditions when are one paroxysmal episode or epileptic seizure in the life of the child. So it really affects the
So frequency is important.
Yes.
So in this regard, so would you recommend this method, this recording, as a screening method, or the patient must be hospitalized for the reason of all night, let's say, recording of their sleeping to find out the patterns?
Thank you. So we initially start with the routine EEG, which is the recording of several minutes or hours. We have the night EEG when the child is sleeping during a sleep period. And we have the long-term EEG, which, as it says the name, it's a long-term, taking even days or weeks in the monitor in order to catch these episodes. And they are investigated in every situation. They are living there in the monitor with their parents during these episodes.